All right, and moving right along, let's welcome our next panel, led by my colleague Chris Dickerson, and talking about our push notifications work, which conceptually similar to the work that's going on in FHIR, is looking to extend the Kira quality governance model into a somewhat different exchange paradigm and architecture. So Chris and panel, come on up.
Hello, everyone. If you recognize my voice, it's probably because you were on one of these work group meetings, so this is what I look like. Anyway, as Dave mentioned, we have been working on push notifications. Very exciting. We have today a panel made up of our 4 co-chairs for the technical and policy groups. So we have Alan Swenson, who's Vice President of Interoperability in No2. We have Bart Carlson, so founder and co-founder of Azuba Health, and founder and co-founder and CEO of Napersoft. We have John Henry Downing, the lead technical project manager at Zen Healthcare IT, and also Holly Miller, the Chief Medical Officer at MedAllies, who has also sat on a variety of work groups and boards, including DaVinci, CMS, Direct Trust, FHIMSS, the board vice chair. Did I miss anything? I think. Anyway, lots of things. So great expertise. And the way that we're kind of formatting this, let me get this a little bit started. Big button. Yeah, that's what he meant by the big green button. So first we're going to give you some history on what we've been doing, how we've been approaching the problem, and some of the kind of problems we're trying to solve with this system. We'll talk a bit about policy from the perspective of push notifications from a policy perspective versus query. So like FHIR in the presentation you just saw, we're using query, the work that's already in the wild and proven itself out to be a fair way of establishing federated communication as our backbone for our approach. Then we'll go through some of the technical details, and hopefully we'll have enough time to give you a solid bit of Q&A. So with that, Alan, if you want to give us some history.
Sure.
I will take a seat.
All right.
It's the big green button.
Pretty straightforward.
I know.
The big button.
Yeah,
the
green button.
Big green button. Anybody coming up behind us, big green button. That's the one you want to go for.
So with push notifications, I mean the main problem that we're trying to solve is obviously there's lots of information about patients out there, and we don't always know where it is or what's going on or real time what's happening with patients. Now care equality with query notifications and the work that's coming up with FHIR obviously solves and helps with a lot of that. At the time of care, I can go and get records that are needed through a query-based exchange today with documents and with FHIR once that's available. I can do a record location query to find information that's available if I don't already know where that's available. But that doesn't all help me with the problem of knowing real-time where the patient was seen. Or knowing, is there information that I should go get somewhere because there's something new that has happened since the last time I got information, or if I'm maybe a care manager or a patient's PCP, rather than waiting until the next time that I see the patient, knowing that an event happened that I should know about and therefore proactively going and getting that information. Push notifications solves that by putting that essentially that alert process in place so that those who need to know when something happens have the ability to subscribe to a specific type of events that we'll get into what those event types are and how all of that functionally works. But you can subscribe to a set of events and be notified when one of those events occurs. So the goal is obviously to create a neutral platform for delivering what we're calling lightweight notifications. And the intention there is that these notifications really aren't an exchange of clinical information, but rather an exchange of a notification that an event occurred.
If you need to get the clinical information relevant to that event, you can do a query exchange for a document, or you could do FHIR exchange once that's available. But the notification is going to tell you the patient was recently discharged from the hospital. Okay, great. Now if you want the information, you can go get it. And that event may just be enough for what you need at the moment, or you can use other carry quality flows to go get that additional information. Obviously, in line with that, we're developing an implementation guide that describes all the policy, technical standards, and everything for that use case. And carry quality is situated to handle all of this. I mean, we're already doing query-based exchange on a nationwide scale. We've got FHIR coming on a nationwide scale. There are local, regional implementations of things with similar types of notifications today, but it is hard to bring that to scale, and that's where carry quality comes in, is the governance that carry quality provides, the trust between participating organizations, the directory of where information is available and how to communicate with other parties. Carry quality makes it so that push notifications are easily scalable nationwide. Getting into some of the policy stuff that Chris brought up. So query-based document exchange has been going on for years and has been through several rounds of iterations of its implementation guide with its policies. So that's largely where we're starting on the policy work. So on the policy side of things, we've had a much easier time than some of the stuff on the technical side of things, figuring out. It sounds a lot like FHIR as well. But we're able to take what already exists with query and bring that into push and then modify what's needed. So we're pulling in principles of full participation, non-discrimination, all of the permitted purposes of use, and some of the most recent updates that are coming in the query implementation guide around some of the non-treatment purpose of use values are also being incorporated in push notifications right from the start, because we're able to take those lessons and just bring it straight across. Some things that we are adding, we do have some SLAs that are being included here, which do not exist in the query world today. Now these are being added today as more just recommendations. They're not going to have any teeth to them. I kind of think the movie Pirates of the Caribbean, when Captain Barbossa is explaining to Elizabeth Swann the pirate code, and he says, really the code is more what you'd call guidelines than actual rules. So the SLAs here are more just guidelines than actual rules. We're putting them in place so that we have something to measure against, with the intention that in the future we will be able to have requirements in place. But ultimately this is all new. We don't know what those are going to look like. There's going to need to be modifications, but we are from the baseline including what we believe are some reasonable recommendations that we can start measuring against as soon as this is available in order to create future requirements.
Thank you. I'm going to take advantage and get some steps while I'm up here. So I actually wanted to find out how many of the folks in the room are clinicians or clinical. So really kind of the minority. And so it's my job this morning to give some clinical color commentary on notifications and why you should feel as passionate about them as I do. Essentially, what we've landed on are 6 notification types. The types are up there: admission, arrival, discharge, gaps in care, referral, and transfer. So they really do cover the spectrum of the patient moving across the care continuum. And let me take advantage of this time to give you a couple of examples and think about either your own healthcare or healthcare of loved ones, parents, children, and why this might be, how it plays out that it's so important. Let's talk about, for example, referral. As a primary care physician, patients can self-refer. I am an internist, so I'm a primary care physician. So my patients can self-refer to other clinicians, and I may not know anything about that. But if I, particularly for my high-risk patients, have signed up to get a notification when they go to another physician, I can then, if they're high risk, follow up with them. That's really important. I'm going to tell you about a paper that tracked high-risk patients and the frail elderly that even in an ambulatory referral, following an ambulatory referral, 20% of that patient population had an adverse drug event following the referral. Patients will be given new medications by a specialist and not be quite sure whether they should be taking their old medications. The way we dispense medications, sometimes they have the generic name and sometimes they have the brand name. So a patient could actually be given a higher dose of a medication that they're on. If it's dispensed with the generic name and at home they have the brand name, they may be confused and actually take all of the medicine and have an adverse drug event. Certainly with discharge and high-risk patients, 20%, so 1 in 5 patients, and this is all comers, not just the high-risk elderly, 1 in 5 patients following a discharge has an adverse drug event. So again, a primary care physician getting this kind of notification, or someone on the treatment team, as Alan referenced, a care manager, can immediately follow up with the patient and prevent this kind of adverse event. And I don't know how many of you have taken care of a parent, but it's sometimes very confusing what meds a patient is supposed to be on after they've been discharged. Relative to their home meds, reconciliation should happen, but does not always. So this is very important. Gaps in care becomes interesting. Gaps in care is something that we're expecting from payers to the primary care physician, because the payer has paid for something. So if I have a diabetic patient and I don't want them to go blind and I want them to have an annual eye exam, they may go get the eye exam, but because the ophthalmologist has not sent me the report, I don't know that it happened. So with a gap in care report, I can see which of my diabetic patients, for example, had an eye exam and which ones didn't. Which of my patients that I've referred for a colonoscopy had a colonoscopy, which one didn't, and follow up with those patients accordingly so that they get their appropriate preventive care. What data is going to go with these notifications? Well, as Alan referenced, we're keeping it really light. We do want to have a core set of data that will enable patient matching, and then if we determine that there's additional data that would be useful or necessary, that can be included. And again, the goal of these notifications is really for follow-up and follow-on communication, be that with the patient, if for the physician, or alternatively, in situations, for example, the arrival. If a physician becomes aware their patient has arrived someplace that has no information on that patient, either that organization can query or the clinician can push the information to the treating clinician. So these kinds of alerts will all lead to further communication to assist with the process of caring for patients. These are required for the 6 communication types, for the 6 notification types. These are our required draft requirements, and then some of the things that we were thinking of as optional. This is not yet determined, these are draft, and so if there are people in the room that are interested, we would certainly invite you to join our meetings and participate. I'm now going to turn it over to Bart for our technical approach.
Thank you. I think that's a key point. This whole workforce is a work in progress. So we're kind of giving you a report today on where we are. We're looking for your feedback, and both during this session, or if you go home and you think of something on your flight home or whatever the case may be, please reach out and give us your feedback and your ideas and so on. So, as we know, notifications have been going on throughout the industry for some time. And along that journey, we're all on this journey, whether it be a technology journey or other aspects of the industry. And so one of the things we wanted to do is look out and see what others were doing before we decided to go ahead with our, doing our own thing, so to speak. And a number of key focuses, areas out there. The use cases for those, were created maybe 10 years ago, 15 years ago, whatever. There's been refinement. We've had changes in technology since that time. And so the groups, both the policy as well as technical, wanted to take a look at this and make sure we, considered what was already in place, or do we need something new? Should we be working with other groups within the industry? We're not just the only group here that's, cares about notifications and how we get there and so on. And so we had a number of discussions that, what are others doing? Where are others in progress? What are the other groups are working on their own notifications, specifications and technology and so on. And so as part of that, we looked, for example, at a number of things. Specifically, I think of all the ones we looked at, we came down to a couple that were both HL7 related, both Da Vinci and Argonaut, and trying to figure out which was the closest aligned policy-wise as well as technical-wise. And we also looked at, what are all the technologies that we're using today. Some of these were built on technologies, as I mentioned, 10, 15, 20 years ago. We have new technologies available to us today. Do we support all those old technologies, or because we're starting new, do we say this is the place to start? And just because it takes a while, number one, to get the work of all of us to put this together and what the standard is, and we all know technologies continue to grow as we go through the journey. I think we're kind of based on right now that we want to start with today's more current technologies. And so as we went into our kind of decision process, if you will, we said, okay, what are those groups that we looked at? And we've, in our early analysis, had decided that Argonaut's work was more closely aligned with what we were doing here with Cura Quality. And so we're actually kind of picking up on some of the work that they've done, mapping it, if you will, to our environment, our network, our processes going forward. And we are also, very much focused on, everything going on with fire. We've had lots of discussions here over the last couple of days in terms of fire. We want to do things that are fire-based in terms of the standards and so on. And so as we move on here in the panel discussion, I'm going to turn it over to our colleague to take a little deeper dive.
Awesome. Big green button. Got it. All right. So what did we turn this into? So we decided to take a simple approach to integrate a little bit with where the industry is at today, but leave ourselves a path to move forward with where the industry is heading. In light of that, we've taken a phased approach. Our infrastructure is going to be fire-based, but for phase one, we're going to be dependent upon the query and retrieve infrastructure that exists today already, SOAP-based as it stands, but that has room to expand as well when that migrates to fire. In light of this, if you were to have reviewed the use case notification or notification use case laid out for our group, you would have seen that there was the concept of a subscription service. In phase one, depending on how you look at it, we're either not addressing this and leaving it for phase two, or we've grouped the concept of a sort of external subscription service into each participant is handling their own subscription service. Also, very importantly, the biggest question that we were struggling with, at least at the beginning, was what happens if I'm trying to subscribe to a patient with you, but you haven't seen this patient before? And this is something that we're still on the path to address completely, but we've determined that the query and retrieve infrastructure in place today has a path for us as participants to have knowledge of patients' demographics and so on amongst each other already. And what that turns into is we have a dependency on that first XCPD query and retrieve to have occurred. And we're expecting that you will either perform a query and retrieve an ID, or have performed a query and retrieved an ID and held on to that ID for a given patient. This is for phase 1. In phase 2, we'll generalize past that. So let me put a picture up here because that really helps, I think. So we have 3 green arrows. The first green arrow is what I was just alluding to, successful XCPD. This is important because I, as a subscriber, want you as a subscribee, I want to communicate to you who it is I'm looking for. I will query you at some point in the past, maybe directly because I want to create the subscription, but more often than not, I've already queried you for some other business case in the past, and I have your MRN for this patient. I will then use this to tell you, hey, if you see event X for MRN 1, 2, 3, 4, let me know. That's what's going on in the purple arrow. In the gray arrow, you've actually seen patient 1, 2, 3, 4. They've actually had the event I'm looking for, and you're letting me know. Maybe there's a little bit of information about the event in this payload. We're trying to keep it light, though. In the FHIR world, what you'd most likely be sending me is an address or an ID for me to come ask you about later, separately. I could even go over the existing query and retrieve framework to get an entire CCDA if I wanted to. But now I have the intelligence to know that there's something new and meaty for me to grab. In phase 2, we're going to abstract a little bit away from the necessary concept of having these, I'm stumbling here. The dependence upon this pre-query, this pre-existing knowledge of where these patients have been, knowing all these various MRNs and having all these pairs of, I know that this patient has been here, here, and here already, and letting us ask in a more general way, hey, have you seen this patient, or if you see this patient that you may or may not have seen, please let me know. Using most likely a bundle of demographics, and we're still in the process of figuring that side of things out. We're also potentially moving away from the concept of each individual participant holding on to the needing to manage all of their subscriptions and letting additional entities handle that either on behalf of those participants or instead of those participants. That's why you see the green discs, I guess, moved outside of the generator. On a workflow basis, it will be materially the same, though. So, it might be a little bit hard to read here. This is what we've laid out as a workflow diagram for an example. This is the example we're actually building sample messages around in our work group today. It comes from one of the vignettes at the end of the use case proposal. But in essence, I'll walk through it a little bit. I, as a PCP, I either already know that you as the hospital have a record for this patient, I have his MRN, or I'll query you. And I'm interested in seeing if this patient comes to you. I want to know if he's admitted or discharged from your facility. So I will send you a message in the first line. I can't see quite what its number is, 1.1 or 1.2 or something like that. And I'll say, MRN 1, 2, 3, 4, if you see an admit or a discharge, let me know. You'll respond saying, okay, I got your subscription, thank you very much. From there, you may query back to me, you may query a record locator service, you may just go about your day, either having seen that patient or not, but then that patient does eventually make their way to you, they get admitted to the hospital. We're looking for that event, we asked you for that event, and you reach back out to us and say, hey, 1, 2, 3, 4 came to me. They've been admitted on this date at this time. It's on me now as the PCP system to decide, is that enough? Did I get what I wanted? or am I going to want to get that fire resource from you? And this is all occurring over FHIR, at least as we have it implemented today. We're planning with JSON payloads. The subscription itself, JSON payload with all the information I talked about. The notification itself, JSON payload, just a little bit of information in there. But the critical piece is, here's an endpoint. If you want to go get this piece of information, minimum necessary, potentially, go get it. And then I'll make my call. I want to get that resource from you, or I don't. I think I alluded to this already a little bit. There's also additional optional workflows that can take place in this scheme. The additional query and retrieve workflow, as well as some others that are escaping me at the moment.
So, we've gone through a bit of the history. We've talked about our stance on policy, and we've done a bit about the technical backing of what we're trying to do. As we've mentioned, the work continues. There's still draft forms of all of this, but we're looking for this group and just generally the community at large to give us feedback. So Q&A. And I see we have our first person.
Hi, I'm Nancy Bevan from Humana. As the payer community, we've been very anxiously awaiting the push scenario. A query scenario doesn't work really well for payers to get medical records, and I guess I'm really missing something here, because one of the things we were hoping to see was that either at a patient discharge or for an ambulatory visit, which I'm not sure I see here at all, that a health system would be able to push that record to a payer, knowing that that patient was a member, an active member of Humana, or of an insurance plan. And so
Sure, and that's definitely all available here. So
explain to me how that would work in this, because I
sure.
didn't see it.
So it's all based on the same purpose of use values that are available in the query world. So as a payer, you could submit to the provider organization that here's my cohort of patients that we care about and that we want to get, ED admission or discharge or whatever types of notifications about. And the purpose for this subscription is payment, or is operations,
risk
or is
adjustment, or whatever,
coverage,
right.
or whatever additional
Yeah.
purpose of use. So when the patient shows up and that event occurs, the record holding organization makes the same determination that they do in the query world today. They look at who has subscribed to this patient and for which purpose have they subscribed. They've subscribed for payment. Well, am I responding for payment? If I am, then they'll go ahead and send you the notification. The notification includes that the event occurred so that you could then query and retrieve back the clinical documents, which would again then be a query for payment. And so it's using that same purpose of use on both sides. So payment would need to have, or operations or whatever else you're using would need to have been allowed between your organization and between the payer and the provider organization.
So I can see how that would work for an attributed membership, but there's a whole lot of members that go to health systems that they're not necessarily attributed to. So I don't know who that cohort is. It's just something to think of. I can't necessarily tell you that this is the list of my members, and without giving you 10 million of them, I can't really tell you that this is who might come to your facility, other than who's attributed to a PCP. That doesn't help me in a hospital scenario. That doesn't help me in an urgent care. That doesn't help me in a lot of different healthcare scenarios where they're not attributed to those provider organizations. And the cohort you're talking about would be an extremely large, probably
Sure. Yep.
too large to handle in this kind of scenario. Just
Right.
something to think about,
And that
because
makes sense.
I'm kind of missing how this would, we're really, as payers, anxiously awaiting all these capabilities with the work we're doing, the implementation guide, to add payment and operations as trusted use cases, and with push notification. But I'm not quite seeing yet in the push notification how it's going to meet what we're looking for.
Right,
So a
and
couple
that makes
things to think
sense.
about.
I would just add that that's one of the things that we've discussed as likely being more handled in phase 2 of the work. So phase 1, as John was explaining, is really looking at building off of what already exists in the query world today of known relationships between organizations. So an exchange has happened in the past, or I query an RLS and it tells me where the patient records exist, and so I am subscribing based on where I already know the patient exists. And that is going to be very beneficial in those cases of, the 80 million records that are being exchanged on a monthly basis and things that are already happening in the care quality world today. In your case where you have, all I care about is this set of patients and I don't know where they have ever been seen or where they will be seen in the future, that gets into what we're looking at for phase 2 of this idea of a subscription service where you would subscribe and say, anyone who ever sees my patient in the future, notify me. It's no longer based on a pre-established relationship of knowing who has the patient.
Okay, thank you.
So just to put that in another, framework, we kind of decided as a work groups to, kind of walk before we trot before we run, and so on. So it's like, do you want this to take, 3 years to do, or can we get something done and started here within the next 12 months, shall we say, and then, have a second phase with the.
It's not going to help, it's not going to be really valuable until we get past.
Right, till we get to phase 2. It's a good point.
And that's the sort of feedback that we're looking for in the work groups, because we do have a large group of very active participants, but sometimes the payer community isn't as well represented among these calls. So if you hear anything in this presentation and you think to yourself, there's a gap that I can identify that they should address, perfect time to send us an email and I'll add you to the work group list. That's the kind of input that we're looking for. And we're trying to adjust for all of these things because fundamentally what we're doing is kind of clearing a new path to do something very large. And we're trying to account for everyone as best we can, but we need to hear that feedback in order to know what we need to build out. Maybe that pushes up the timetable for subscription service. Maybe we've already tried to do a little bit in that, incorporating the updates from Implementation Guide V2, more on that in the next session. But all of those payment, healthcare operations, support sort of policies, we're from the get-go including that in this implementation guide. So we're trying, and we acknowledge that that's there, but we do need more feedback. Anyway, don't know which, okay, go ahead.
Hi, I'm Linda Michelson with Optum, and I have the pleasure of being both a member of Argonaut and a member of Da Vinci and participating in both of their use cases around subscription. And what I would call Argonauts, or what we call it, is the solicited notification of when you go to their server and you subscribe. And like Dr. Miller mentioned, if you don't know the patient is self-referring somewhere, it doesn't help you. That's also, I think, what Nancy is talking about. And that's where the Da Vinci, and I respect the fact that that could be phase 2 for you, but the Da Vinci is working on the unsolicited response, which is the ADT equivalent for admit, discharge, and transfer, which would be pushed. Now, I say equivalent, Hans is to my left here, I think, and it is not an ADT in FHIR. It is a notification that transmits the same information that you would receive, and there's absolutely a purpose for that. One of the technical questions I had for you as I was standing up here, somebody said, well, in phase 2, we're thinking of doing an all-in subscription. I'm not clear how you would do that. That's one thing. And then the second thing I wanted to mention is right now, the subscription paradigm, when you subscribe, the most you will get back is a resource, perhaps in the admission, discharge, transfer, and encounter. And some won't even push that, right? They're just going to push that your your subscription got hit. So you almost always, unless you're a tightly integrated system, are going to have to go back and get more resources to even know who the patient is in your paradigm. So neither is good or bad. They have different purposes. And I don't think, like Nancy mentioned, until we have the full equivalent of both, are they going to be useful to everyone.
Good points.
Yeah, join the committee, Linda.
That's right. We need some more payers on the committees.
All right. Good morning. Derek Plansky with Healthy Nevada. On the use cases, the 6 alert types, it's good that those have been clarified, but it feels a little bit like the use case that you're starting with is a well-trod path for, there are at least 6 vendors doing it. It's a core bread and butter to a large number of health information exchanges. It would seem to me that you could provide more value by focusing in the areas where there aren't existing solutions, like the referral. That seemed like a very novel use case, and certainly the gaps in care, getting that feedback from the payers to the providers, that would be huge. So just from a prioritization perspective, instead of doing the discharge from the hospital, which seems to be a very well-trod path, I'd recommend going to those other 2 use cases that are less well-trod.
And that, yeah, and I mean, I think we agree that is a large part of the discussion that led to what our initial set are. And in our initial discussions, we had a whole lot more than just those 6, and we've had to kind of narrow it down to where do we start, and then we can expand from there, but we have to start somewhere. And the idea that, admit, discharge, transfer are the types that everybody's already pretty familiar with, but those today largely aren't scalable at a nationwide level. But care equality can make that scalable, and then add on some of those novel care gaps and referrals and others to start with as well, and then continue to expand from there.
So I would just push back on the scalability part of that, because most healthcare is local. As soon as you start scaling it, you have the duplication of patient identity information all over the place as you starting to discuss with your architecture. So it feels like it's more of a regional solution for the core ADT pieces, but that's just my opinion.
Yeah, I think I agree with you. So at the state level, right, have you guys given any thought to work with the HIEs at the states? Because a lot of the payers and the healthcare organizations are submitting rosters to receive event notifications to it, but then taking that as a foundation and then building upon the national framework to go into your phase 2 approach. Conceptually, I understand how you guys are going to do it for phase 1, but if we're looking to incorporate the payer subscribers and the healthcare facilities that are submitting a roster of patients, have you guys given any thought to that?
Yep. And there have been some HIE participants in the work groups, but you're both going to get invites as well now. So
I want you to.
And then, is the focus primarily on the acute side, or are you spanning it across the network to SNFs and long-term care facilities as well?
I think it's pretty clear from the notification types that we really are looking at both the ambulatory world and the acute world, and we feel that they're equally important. The last thing that I want to suggest, particularly as a provider, as a clinician, is any kind of patronization or paternalistic approach to the patient. But this is really working as a patient partner. Mm-hmm. The provider is partnering with the patient and facilitating understanding or enhanced understanding as patients transition. And I think that,
right.
That's, and I wanted to convey that to this group because that's my passion in this project. I think for clinicians, and I'm glad you brought up that these are 2 different and unique alert notification types that we're looking at, because we really feel strongly that we can make a huge difference in patients' lives. And it's not in a paternalistic way, it's really in a supportive way. Yeah. We are looking in further phases to the notion, which was in the draft proposal, of patient delegates also being able to receive notifications. So really we want this to function in a stepwise process, and as we learn more, as we see what's working, to keep moving forward.
One other thing is, with the notifications that you all are looking to bring in, I know we're looking at ADT at a high level, based on the information that from our feedback from clinicians that I've worked with, they want more clinically relevant data, not just the ADT. So I would keep that in the back of your mind as well when you're delivering the data to the providers.
The notification itself is meant to be light. You're only going to have knowledge of something happening. It then is on the receiving system of that notification to make a request. It can be very targeted, or it can be, collect a traditional, go get a CCD.
Okay.
And
Well,
I would just add as well, I mean, because this is all through carry quality, and so the query exists, fire will exist as well, that incoming ADT notification or whatever other type of notification it is doesn't necessarily show up to a provider and that's all that they see. The system could use that as a trigger to automatically go get the additional clinical information via a query. So even though the notification itself is lightweight and doesn't include the clinical information, it can be used as a trigger depending on the type of event and the recipient and what they need to know at that time. It can be used as a trigger to go get the clinical information.
Well, and also I do want to bring up that the regulations that went into effect November 29th mandate that the acute facility on discharging a patient send the information to the next care provider. So if the patient's going home, that would be the PCP. If the patient's going to the skilled nursing facility, that would be the skilled nursing facility. So this is now a condition of participation for Medicare, and we are hoping that with current mechanisms in place that these messages will be going out so that it may not be necessary to query because there might be a direct message that's gone to the provider or to the skilled nursing facility. So I think the notification is critical, particularly as not everyone has the same capabilities if they're not using CERT. So again, it's stepwise, and we'll see what works best.
That was one of the optional workflows, actually, was different parties knowing that a subscription exists can use that knowledge to initiate a push, which is a little bit outside of the scope of immediately what we're working on, but that's an opportunity.
What we have heard a lot from providers in doing the work around notifications is the expression of, tell me enough that I know if I care when you send the data. And that's, and the back and forth on that is a challenge sometimes. I know it's the way APIs work, so, technically it's doable. The only thing I wanted to mention was Da Vinci also has a gaps in care work group going on. If you're not aware of it, we probably should align on some of that work so that we're not doing redundant, different things.
And Linda, I wanted to address that because that's something that actually in this process that was thought about, and I referenced high-risk patients. So lots of practices now are risk stratifying their patients, and I may only want to subscribe to specific notifications for my high-risk patients. So I think that when you say, tell me, do I really want to know? Well, you may be able to then subscribe to the patients you know you need to know about. And I think that that's a really important thing because we do not want to overload. We don't want information overload because that will be a turnoff to providers.
I totally agree. I think it's more about what do I send when in the subscription, right? So it doesn't make you be highly chatty to find out if you care.
The framework that we're trying to put into place right now is driven by patients, and we haven't figured out all of the topics that would exist within a patient. So we use in our examples, we're talking about unadmit. There's the possibility to make that very granular. So you can when you establish your subscription, can specify very specifically which types of admits and what types of events. So by virtue of receiving the notification, you know that you care.
And I would just say that Da Vinci's done some of those similar concepts, so we should actually align. We don't have a list, we have a list.
And it's our understanding that both the Argonaut and Da Vinci work groups are working to
They totally are.
we're going to merge one way or another.
In the fact that we, Argonaut members join Da Vinci discussions all the time. And they're open. Anybody can join the work being done either in the Da Vinci gaps in care or the Da Vinci notifications.
shameless plug. We meet on Wednesday. So just one of those things.
And again, I have to be the cutting off of the discussion guy, but Joe, you've been patient, and Scott, you need to stand up sooner, man. But Joe, go ahead and round things out.
All right, I'll keep my questions brief. Two brief questions, and maybe you can answer them or not. The first is, in phase 1, you have you've already done a patient match, and then you subscribe to a known patient, and then you get a response. And in the required data that comes back, you've got demographics for the purpose of making a match. And so in phase 1, you've already made a match. So do you also include the patient ID so somebody doesn't have to go through that probabilistic match again?
Yep, that's all stuff that we're discussing
Okay.
on the technical side of what's actually included in that message. So it, like you said, because the match has already been established, we both already know the patient ID, it may not actually need the demographics, or maybe some
Right.
demographics are included to confirm that this patient ID is actually who I think it is, but we are talking about what actually needs to be in there to verify this is the right patient, and subscription IDs and things like that.
Okay. And the follow-on is it's unrelated, and that is when you were identifying the events of interest, knowing that vendors have already got implementations where X happens and Y event goes out, did you find any harmonization issues where vendor X triggered in these cases and vendor Y triggered in almost the same cases but not exactly the same?
And that's also, that is a consideration that we've talked about. I mean, discharge from a hospital, we can kind of align with, well, if you count this in your denominator for meaningful use or for MIPS, then you should be including this here as well. For some of them, it does get a little more complicated. And we did a lot of work looking at HL7, ADT definitions for these events, and that's where a lot of this gets complicated. Is you can use an AO3 or an AO, whatever, pick your favorite number to stick after the AO for this or for this, or you can use it for this or for this. And that's a big part of the problem with ADTs today is they are set up between two organizations who do all of the mapping together and agree on what does this mean, right? And now, so when you say discharge and I say discharge, we know that we mean the same thing because we mapped it between each other. When we start trying to make that scalable nationwide, when I say discharge and you say discharge, are we talking about the same thing? So if we're just based on an HL7 definition, we're probably not talking about the same thing. And so we need to define in the work group, and we are starting that, of what do we mean when we say admit? What do we mean when we say discharge? And that is going to be a constraint upon the existing definitions that are already available from HL7.
Thank you.
We're a fun group.
Huge thank you to everyone. This was a great session, and this kind of discussion is exactly what we're looking for, so really appreciate that. But huge thank you to Chris and our panel members as well. Thank you, folks.